The other study that came out, Calder, Journal of Trauma, this was a multi-center study. It was a cohort study of close to 2,200 patients. There's a secondary analysis that's being done as part of a larger algorithm to find a low-risk CT evaluation rule, something similar to the catch rule or the PCARN rule for the head. We're trying to figure out who are the patients that we don't need a CT. And I think part of that's going to depend ultimately on what do we care to diagnose, because there's going to be a lot of grade 1 splenic injuries that we would potentially miss and otherwise not even care to know someone had in all likelihood, right? But that's going to be where we as a group need to determine what our threshold for caring really is. Because as you know, there's this kind of idea of injuries and then there's clinically significant injuries. And so that's where we have to sort of make our discrimination in the use of CTs about. Huge variabilities between centers in terms of how much CT they did, how much FAST they did. Some centers did as much as 95% of the time they were doing a FAST. Some centers did almost zero. So, that just reflects reality. In terms of intra-abdominal injury, very poor sensitivities in both that as well as for the need for intervention. So this does not reflect favorably on using the test as a binary decision tool for whether somebody has an injury. But again, we didn't necessarily think that was what we wanted the FAST for in the first place. So these numbers, though, are, however, much worse compared to some of the previous quoted studies that have been out there. And this was a larger study, probably the biggest study that's been done so far in kids. So keep that in mind, that the FAST is seemingly pretty unreliable from a standpoint of sensitivity from what we most recently know about it. Okay. Quickly talking about different things, because it's not all bad. We have to think about the FAST in different ways, right? So this is a slide that I sort of stole from Leanne. Whoops, I don't know why that one has an animation. The FAST is not a test that's isolated at the time, right? So a CT is one test you're going to do, and you're going to think really hard whether you're going to CT someone again in any case, right? It's easy to do the first one. It becomes a lot harder to repeat scan somebody, even though sometimes that might be necessary. Whereas a FAST is a test you can do a dozen times and there's no complications for the patient from, and really should be something that can help you guide as things are kind of progressing with the patient, whether something might be changing. So a patient who has a negative FAST and now has a positive FAST, that's information, regardless of whether you can call that the most useful or evidence-based or whatever. That's still information about the patient that probably tells you a bit more about what's going on in their body. The other area that we have to think about is where we're using the FAST, right? So we're here in an academic center. We have access to a CT. What about in transport, right? What about on a plane or on a EMS crew? They don't have a CT scanner there. They might be going long distances. So using the FAST can sometimes help dictate where are they going to take that patient, what interventions are they going to give. And of course, some of the same stuff is true within the low resource setting. So in a developing world or in a multi-trauma issue like a disaster scenario where a CT scanner is going to be filled with patients, can a FAST be helpful in that case? Probably it can be very helpful. So it's probably not reasonable to think that we need to stop doing the FAST just because it doesn't answer this binary question in the ATLS kind of algorithm. But it's something where it may have roles that become a little bit more kind of pigeonholed as we find its utility kind of sorted out through further study. Remember, as final points, stop thinking about ultrasound versus CT. I think that argument is pretty much over in the standpoint of is an ultrasound equivalent to a CT? It's just not. We know that that's the case, and so we need to stop having that argument with trauma surgeons that come in about them saying this doesn't replace a CT, or us saying they need to go for CT or they don't need to go to CT on the whim of what a FAST says, and start thinking about it in a more holistic sense. Though it may keep us from doing a few, at least the evidence would suggest that it does help kind of getting your brain that much further along to say, I'm pretty darn convinced there's nothing going on in this abdomen we need to scan right now. Think about the FAST as more helpful for your own cognitive load. Knowing that this kid doesn't have a belly full of blood right now is sort of a useful thing in its own right. Incorporating it with the rest of their clinical picture. So in a completely normal patient, a positive FAST shouldn't make you freak out. In a completely abnormal patient, a negative FAST shouldn't make you not freak out. And that the test can be used in a serial format. These are probably the next areas where research might go, figuring out where the FAST fits into a whole lot of other information that we're gathering about a patient. And then keep in mind that the uses of these views are not just for trauma. They can be used to look for things like free fluid in the setting of appendicitis, where you might think about perforation. They can be used for PID, and they can be used for ectopic pregnancy classically, where you can look and see whether there's free fluid. So free fluid in a pregnant patient, ectopic is your number one thing you're trying to rule out, right? So these views are not isolated just to the trauma setting. That said, I've gone way over time.